Welcome to the 10th module of this series, Avoiding Communication Failures. To recap from the prior module, developing awareness of blind spots can be accomplished by following up your cases to identify when subtle findings are missed, developing a robust peer learning system that focuses on identifying opportunities for improvement, review articles and literature discussing common blind spots. There are interventions that can help reduce blind spot errors that include using dedicated fields in structured reports to ensure that radiologists remember to check known blind spots, and reviewing the entire field of view for diffusion-weighted images to reveal unexpected findings. The goal of this module is for learners to understand how to avoid communication failures that can result in delays in diagnosis and treatment. The learning objectives are to describe scenarios where communication failures occur involving radiologists, and discuss the importance of communication for unexpected findings. In this first case, we have a patient with history of endometrial cancer and has a new pelvic nodule that is called concerning for recurrent peritoneal implant. You can see the nodule in the left deep pelvis on the CT on the left in comparison to the prior CT 2 years ago on the right. A CT-guided procedure is performed 2 months later, despite the fact that the new nodule now is significantly smaller in size. This was not mentioned in the report. You can see the CT-guided procedure CT on the right in comparison to the prior CT on the left. A PET CT is performed several days after the biopsy, and it shows mild FDG uptake in the nodule. This is reported as suspicious for peritoneal implant, even though it continues to get smaller, and the increased FDG uptake may be related to the prior procedure. Pathology was non-diagnostic. This case was reviewed at tumor board, and the radiologist recommended repeat biopsy because it had been concerning. He hadn't realized that this nodule had gotten smaller over the following PET CT and procedure CT. When he went to talk to the interventional radiologist about repeating the CT, that's when they mentioned that this nodule had gotten significantly smaller, and that's why they didn't expect to get cancer out of the biopsy. Given this new information, a repeat biopsy was not performed. It's important that reports don't miss important information that can impact the diagnosis. This is a patient who had an ultrasound in the ER for left groin pain, and the radiologist identified a bowel-containing hernia. This was communicated directly to the PA in the ER. The radiologist also identified an incidental right testicular lesion and recommended urology follow-up in the report, which was issued after the patient was discharged from the ER. The patient was lost to follow-up and returned a year later with metastatic testicular cancer. During the malpractice case, the radiologist said that he had communicated both the hernia and the testicular lesion to the PA in the ER by direct communication, but his report did not document this communication. The PA said that he only communicated the hernia, and in her documentation, she noted that he only reported the hernia. This case was settled, and the radiologist was considered negligent. This is a CT of the chest, abdomen, and pelvis performed on a patient after fall, and it was interpreted as no acute traumatic injury by the on-call resident. The patient was subsequently discharged. The attending reading the case the next day identifies a subtle sternal fracture and reports this in the final report but does not communicate this to the ER. The ER physician did not know there was a significant change, and the diagnosis was delayed. This is a classic scenario where important findings are not adequately communicated when there is a prelim read and a change the next day after the patient has been discharged. I'm going to show you a case of a wet read. A surgeon calls the radiology department for a prelim read on a patient he has in the office who had cholangiocarcinoma resected. The resident quickly reviews the study and tells the surgeon that he doesn't see anything. Later, the attending identifies a new peritoneal implant that's reported as concerning for recurrence. This was not directly communicated to the surgeon, who then called the radiologist several weeks later, very angry that the patient found out by accessing his report in the web portal. Wet reads in general are like curbside consults. I strongly recommend against this practice. When I'm asked to provide a prelim read, I say very politely, I do not do prelim reads, but I will be happy to call you back when I've had a chance to look at the complete study. One of the downsides of providing these wet reads is the patient is told they have no evidence of recurrent cancer. because the radiologist or the resident misses a subtle finding. The patient goes home thinking they don't have recurrent cancer, and then is called the next day by the ordering physician who says, "We made a mistake, you do have recurrent cancer." I don't think this is high-quality medicine. Here's an example of a voice recognition error. The report says multiple indeterminate liver lesions that could represent cysts or hematomas. A follow-up MRI was performed to evaluate for possible liver hematomas. What the radiologist intended to say was cysts or hamartomas, and an unnecessary MRI was performed. Voice recognition errors are prevalent. In this case, a patient presents to the ER with abdominal pain and is found to have a bowel obstruction. The radiologist communicates this directly to the ER physician. He then identifies an incidental enhancing pancreatic lesion and reports this in the final report, but does not communicate this directly to the ER physician. The patient returns almost a year later for follow-up CT performed for abdominal pain and is found to have a liver metastasis from pancreatic neuroendocrine tumor. The incidental pancreatic lesion identified on the CT was not followed up because the ordering physician did not know that it had been reported. This is a case of a 43-year-old transferred for sternal fractures and rib fractures. There is a comminuted fracture dislocation of the right hip that was not communicated during transfer. The outside CT exam was uploaded into PACS, but it was not interpreted. This patient was subsequently discharged and returned a month later, where it was diagnosed on a plain film study that was performed for persistent hip pain. There are some practices who routinely interpret outside studies because it provides significant value. There was an optional reading in Module 8 that was a systematic review and meta-analysis of outside reads, and I suggest that you take a look at this study. Let's quickly review some of the salient points from the ACR practice parameter on communication. The final report should be proofread. Use of abbreviations or acronyms should be limited to avoid ambiguity. The ordering physician or other relevant healthcare provider also shares in the responsibility to obtain results of imaging studies he or she has ordered. As soon as possible, a significant variation in findings and/or conclusions between the preliminary and final interpretations should be reported in a manner that reliably ensures receipt by the ordering or treating physician or healthcare provider, particularly when such changes may impact patient care. Documentation of communication of any discrepancy should be incorporated into the final report. The following are situations that may warrant non-routine communication. Findings that suggest a need for immediate or urgent intervention. This is the critical result. Findings that are discrepant with the preceding interpretation of the same examination and where failure to act may adversely affect patient health. An example is the resident prelim with a significant discrepancy when the attending reads it the next day. And findings that the interpreting physician reasonably believes may be seriously adverse to the patient's health and may not require immediate attention, but if not acted on, may worsen over time and possibly result in an adverse patient outcome. These are the unexpected findings, the indeterminate findings, that are considered actionable. In all cases, the interpreting physician should document all non-routine communication. To summarize, here are some of the scenarios I've shown where communication failures occur. When imaging is done in the ER, there is an acute problem as well as a non-urgent incidental finding that requires follow-up. A report with multiple important findings where only the most urgent finding is directly communicated to the ordering provider. Significant changes in preliminary reports for patients that have been discharged from the ER and are not communicated directly to the ER. Recommendations for non-urgent follow-up that are not communicated using a closed-loop system, particularly for outpatients. Unclear and ambiguous reports, and when patients are transferred from one hospital to another. In the next module, we will discuss how to reduce malpractice risk in radiology.